Thank you very much, Stuart. It's a great pleasure to have you host our first webinar. I thought it would be helpful if I gave just a brief rundown on the Hunter branch of the Royal Society of New South Wales. It was only formed in 2019, and this year was to have been our first ambitious program of 6 public lectures. We held a very successful public lecture on mathematics in industry at the end of January, but then, of course, along came COVID-19, and as a consequence, we've had to postpone the next 2 lectures. But it's been a great start for our branch, and I thought it might be appropriate, just by way of introduction, if I was to introduce you tonight to our committee members. The Vice Chair is Laureate Professor John Aitken. The Honorary Secretary is Emeritus Scientia Professor Eugenie Lumbers. The Honorary Treasurer is Professor George Willis. Committee members are an Emeritus Professor John Bolton, Father Andrew Doohan, Mr John Dunnett, Professor Brett Ninnis, Professor Natalie Thamwattana, and Adjunct Professor Robert Whitaker. And they join me on a very active local committee. Tonight we're going to hear from our Honorary Secretary, Eugenie Lumbers, on COVID-19 and confusion, the story of a nasty but nice viral receptor. Eugenie studied medicine at the University of Adelaide. She subsequently gained a doctorate in medicine for her research into the renin-angiotensin system. She was the first woman to be awarded an NHMRC C.J. Martin Fellowship, and she studied fetal physiology at Oxford. Returning to Australia, Eugenie joined the University of New South Wales, where she developed her research on fetal physiology and was awarded a doctorate in science and a personal professorial chair. Subsequently, she was the first woman in New South Wales to be awarded a Scientia professorship. In 2002, she was elected to the Australian Academy of Science and made a member of the Order of Australia in 2012. Eugenie retired in 2003 to go sailing, a very noble thing to do. In 2007, she began work at the University of Newcastle, where she holds an adjunct professorial appointment. She also holds a similar adjunct appointment with the University of Queensland. Eugenie is still actively involved in research at the University of Newcastle in the Hunter Medical Research Institute. Her team has been developing a research program in ACE2 enzyme, amongst other components of the renin-angiotensin system. And tonight she is going to speak to us, as I say, on COVID-19 from her particular perspective, her area of research. And we have the facility tonight to take questions. So Eugenie will talk for 40 or 45 minutes, and Natalie will corral questions through the chat facility and then manage to have Eugenie hopefully address all or most of them at the end of her speech. So thank you all very much for attending. I'm sure it's going to be a wonderful evening. And Eugenie, if you're comfortable, let's get started.
Hello, and thank you very much for helping me set this Hunter branch meeting up. Okay, tonight I wanted to talk about COVID-19 and confusion. It's the title of my talk, because I wanted to tell you a story of a nasty receptor for a nasty virus. This is the coronavirus here, but a receptor that in many other ways is life-saving and very important. As the Chancellor said, I work at the HMRI. I'm not the team leader. My team leader is Kirsty Pringle. I'm just a member of the gang. And I just wanted to pay tribute to their participation in the work that we're doing in this area. But let me tell you, I'm not a virologist. I know nothing about viruses. I don't know much about anything, I think, except I know something about this system, the renin-angiotensin system. So what has that got to do with this virus? Well, a key enzyme in the renin-angiotensin system is, in fact, this enzyme ACE2. This is the way the coronavirus gets into your cells. And we have been looking at ACE2 in pregnancy and in the placenta. And so when the coronavirus first turned up, I was mildly interested because it was going to be a cause of a pandemic, and its receptor was this enzyme, which plays an important part in managing the renin-angiotensin system. The SARS virus binds, as I said, to this receptor. But then I got very concerned because drugs that are used to block this system are very widely used in the treatment of high blood pressure, diabetes, and heart failure. And people got concerned because they might upregulate ACE2 and increase susceptibility to COVID. In actual fact, you will probably know from reading the media that COVID-19 is nasty in the elderly and it's nastier in men and women. And in fact, 2 very recent papers have appeared showing that if you're young and you're female, the amount of ACE2 you have is less than if you're old and male. Sorry about that. Furthermore, the young have less ACE2 in their nasal passages, which is possibly why they don't get the infections as often as us old people. But the medical profession was starting to mutter about, well, okay, these drugs might upregulate ACE2, and that would make the infection very much worse. Now, that started to make me fairly cross because they were condemning a group of drugs that are really powerful, are very useful in the treatment of these conditions, very widely used indeed. So I thought I ought to tell my story about our story about the renin-angiotensin system and the role of ACE2 and its interaction with COVID. I tried to tell Lancet this story, and I tried to tell the Medical Journal Australia the story, but they weren't very interested. And then I got very cross because The Conversation published an article claiming that this was a dangerous side effect of these drugs. And, well, hinting at, I shouldn't malign them too much, but making me angry enough to offer to write an article refuting this argument, which they didn't want to know about. Anyway, we got our paper published last week, and what's happened over the intervening period since my first attempts to tell this story have been that many more clinicians have come out saying what I was saying, these drugs are not dangerous, and secondly, even beginning to say that they may be important in treating people with COVID-19. So some of you will have high blood pressure. About 30% of the population have high blood pressure. Some of you will have diabetes. These are very useful drugs indeed for treating your condition. And there's no real evidence that any upregulation that these drugs causes significantly affects the susceptibility to COVID-2. But there is evidence appearing now that these drugs do help treat COVID. These are drugs that block the renin-angiotensin system. We'll call them the ACE inhibitors or angiotensin receptor blocking drugs. That's what those acronyms stand for, because the medical profession love acronyms. This is a paper that appeared this year showing that the mortality rate of people who were taking these drugs when they got COVID-19 was only about 3.7% compared to those people who were not taking them, where the mortality rate was 9.8%. Now, that's a pretty powerful protective effect of these drugs. And what I want to show you is how this happens scientifically. But to do that, I've got to tell you about the renin-angiotensin system. So sorry, we're back to Physiology 101. If you're an injured, sick, dehydrating, hemorrhaging animal, your blood pressure is likely to drop. Now that evokes the release of this enzyme renin from the kidney. And renin acts on a protein from the liver to form a small molecular weight protein, angiotensin 1, which is converted into the lungs by ACE. Forget about ACE2 for the minute. And once converted to ACE, what ACE does is take off another couple of amino acids, and you end up with this most powerful of the peptides, angiotensin 2. Now, angiotensin 2 goes off to the body, acts on the brain, the blood vessels, the heart, the kidneys, and the adrenals. And what it does is restore blood volume and maintain blood pressure. So it is a system for survival whenever any of these events happen, or even into day-to-day events like getting up in the morning. So it's a very powerful system. This is the circulating renin-angiotensin system, and it's a very old system indeed. I just wanted to show you how old it was. ACE and ACE2, which are the two key factors in tonight's talk, they were here about 550 million years ago in human evolution. Angiotensin 1 and angiotensin 2, angiotensin receptors, were here round about this time in evolutionary time. And here, over younger than all of these, is the protein from the liver, angiotensinogen, and renin being incorporated into a system that I have just shown you. And finally, we have the new one, young one on the block, namely the MAS receptor, which I'll come back to in a minute. So you can see this system turned up in its full glory, or variations, slight variations thereof, way back when lampreys and sharks were first making their appearance. And it's a survival system. Now, not only is it a survival system in terms of the circulating renin-angiotensin system, there are tissue renin-angiotensin systems. And this turns the system into a system survival and a system for damage. Here we have what I've just shown you, angiotensin yielding up angiotensin 2 under the influence of renin, but probably other tissue proteases as well. And it acts on this receptor, to 81 receptor, to have effects on blood pressure, blood volume, and to save our lives. But as well as that, there's a relatively new arm discovered only 20 odd years ago, and this is ACE2. Now, what ACE2 does, it metabolizes angiotensin 2, converting it to this peptide. And I'm sorry about all the tedious names, but ACE2 is very important because I would call this the angry fighting arm of the renin-angiotensin system, fighting for survival and fighting in the tissues, as you'll see. And this enzyme ACE2 is so important because it breaks down angiotensin 2. And not only does that, but in doing so converts it to this nice calming peptide, which acts by the MAS receptor, the latest one on the evolutionary timeline. So what does this mean? Well, here's another way of looking at it. Here we have angiotensin 2 acting on the AT1 receptor, maintaining blood volume and blood pressure and keeping us upright. But in tissues, it will do lots of things, but for the purpose of our talk tonight, it causes inflammation, cell death, and fibrosis. It's nasty. That's why I've got a nasty emoji. Angiotensin II acting via this receptor and the MAS receptor, which is acts on which angiotensin 1 to 7 acts, in fact, remove angiotensin 2 from the system and form angiotensin 1, and so both of them together suppress inflammation, cell death, and fibrosis. So this one is balanced by this system, and they are intimately related. When one goes up, the other goes up, although there is some suggestion that this system can downregulate the angiotensin 1 to 7 system. Right. Well, that's the renin-angiotensin system, but you didn't come along to hear about that. You came to hear about the COVID. Now, we rarely think about the renin-angiotensin system as causing damage, or as a survival system. So, but please keep it in your mind and see how important it is in some ways. Instead, we always think about angiotensin 2 as causing high blood pressure and damaging the kidneys. Now, this should tell you something about those actions of angiotensin 2 that I showed you in the previous slide. And in fact, the tissue probably have a number of angiotensins, small peptides, that all act via that AT1 receptor. So how does this relate to SARS-CoV-2? Well, as you all know from watching the news and at 7:30 report or whatever, this is called a coronavirus. There are about 30-odd coronaviruses or so. And they are called corona because they have these proteins sticking out from the surface that form a corona around the viral particle, like the corona around the sun, or corona solis. There are three that are particularly interesting from my point of view. One is this one, which goes by the brilliant name of HCOV2 NL63, I can barely say it, is very, very common in children, causes 10% of upper respiratory tract infections in children and only causes a mild infection. Then we have SARS, or sudden acute respiratory syndrome, which was what we struck the world back in the early part of this century and then faded away, really before there was any consistent development of vaccines, etc. Where would we be today if more work had been done? And then this guy is MERS, that uses a different receptor, but that's the other one that's been in epidemic form. CoV-2, this guy, and SARS all use the ACE2 of the renin-angiotensin system to get into the cell. And this is how it does so. Here we have our CoV-2 membrane, cell membrane, and sticking out from that membrane is, as I said, this spike protein. Now, the spike protein has two little bits to it, the S1 subunit and the S2 subunit. Here we have a poor little cell with its ACE2 sticking out into the extracellular space. It's what's known as an ectoenzyme. And it's sticking out there waiting to catch any angiotensin 2 that comes along and break it down. But along comes the SARS virus instead. The protein, this protein unfolds and grabs on to the ACE2 that's sitting out, the part of the ACE2 that's outside the cell. And so now we head down the track of having an infection. So let's look at what actually happens in a bit more detail here. Here we see our virus coming through and it meets the receptor. There's the spike protein, and it's this S1 subunit that the the ACE2 receptor binds to. Now, when that happens, we have to go down here and we see that in actual fact, some enzymes within the cells get to work, and these are important enzymes for coronavirus infection. They break off this S1 and leave the S2 unit stuck on the virus. One of these, TMPRSS2, a dreadful name, is so important that it's the major pathway by which coronavirus gets into the cell. If you block that, you will block the viral infection. And this is a drug that's already in clinical use, nafamostat, which we won't talk about much, but I just want to point out that there are drugs around that will work to limit this viral infection. But what I want to show you here is what happens to this snipped off S2 subunit. Well, it has a whole lot of fusion peptides exposed as a result of these enzymes' actions. And as a result of that, it can fuse with the cell membrane. Here we have it fusing with the cell membrane, and that gives it the opportunity to inject all its nasty bits and pieces into the cell and take over protein production to make another virus. So that's how it gets into the cell. That's how it makes more viral particles. I can't help you much more on that. I'm no expert. What I want to look at is what happens to this ACE2 receptor bound to the S1 subunit. Well, I'm sorry, another enzyme comes out and it cuts out ACE2, which is shed into the blood. In fact, this enzyme goes by the name of shed-ase in some publication. Now, angiotensin 2, remember back that I said it caused lots of effects. One of its effects is to stimulate the actions on the production of taste. So it accelerates this cutting out of ACE2. Now, ACE2 is cut out of the cell where it's protecting the cell. It's shed as soluble ACE2, and now the cell has no protection. What you get then, I'll show you in a tick. I just want to mention again, we have another drug, a TACE inhibitor, and if you give that will prevent viral entry as well. But what I'm interested in showing you is what happens when we take the poor cell loses its ACE2. Now, here we are back at what you've seen before. Angiotensin 2 doing the survival thing and doing the inflammatory thing in tissues. ACE2 limiting that by breaking it down to angiotensin 1 to 7, which counteracts all these actions in the tissue, suppressing inflammation. And that's why I have this calming emoji. Now, along comes the coronavirus, and of course the result is that whole arm disappears. And now we're left just with angiotensin 2, and we're left with lots of it, I might say, acting on the AT1 receptor, causing inflammation, cell death, and activation of fibrosis. What is the impact of this removal of ACE2 from the cells and tissues of our body? Well, first and foremost, is to realise that ACE2 is located in nearly every organ of the body. It's just a carboxypeptidase enzyme, and it's everywhere, in lungs, heart, kidneys, testes, intestine, brain, uterus and placenta, which is our particular area of interest, and nastily in fat tissue or adipose tissue. And a nasty paper came out showing that 88% of non-survivors from COVID-19 were overweight or obese. That is, they had a greater BMI than 25 kilogram per metre squared, compared with only 18.9% in survivors. So obesity seems to be, because there's so much ACE2 in it, If you take the ACE2 out, you tend to be sicker if you take it out of these tissues. And in actual fact, this again, I think, comes from Scientific American. In serious cases, you get infection in all these organs. Now, look at the lung. The ACE2 has released so much, loss of ACE2 has released so much inflammation that you get an acute inflammatory reaction, you get mucus forming, you get the very delicate membrane between the blood and the lung can no longer transmit gases across it. So the patients with COVID-19 and severe lung infection are literally gasping for oxygen. You get it attacking the lining of blood vessels because it's located on the lining of blood vessels, and you get clot formation. It probably gets into the brain and almost certainly, I think, gets into the olfactory bulb, because you'll remember there's been a lot of press about losing your sense of smell if you have COVID-19. I go around checking my sense of smell all the time these days. And that the olfactory bulb is just adjacent or very close to nasal passages. It occurs in the eyes, and there's a report of it causing hemorrhages in the eye. The nose, of course, is the pathway by which it gets in. The lungs we've already discussed. And the kidneys, which are very important organs in terms of the whole renin-angiotensin system, also have a lot of ACE2. And they are really second on the hit list for the coronavirus to cause damage in. And so the complications of kidney failure are quite common. And finally, interestingly enough, in the intestine, ACE2 acts as a transport protein. And so, of course, the SARS virus latches on to the ACE2 in the intestine. And I think that accounts for the diarrhea that is people who have COVID-19 complain of, or which is listed as a symptom. But I want to return to the lung, because remember we had a circulating renin-angiotensin system, our survival system. Now, renin, as I said, is produced by the kidneys, gets into the renal venous blood and lymphatics, and it makes angiotensin 1, which then gets into the lungs, and in the lungs, it's converted by ACE to angiotensin 2. What is nice is that the lungs have a large amount of ACE2, presumably protecting the tissues of the lung from the angiotensin it makes in the blood and from the angiotensin 2 that's maybe in its tissues. So this is how I see the story. Angiotensin 2 is formed by the cells lining the pulmonary blood vessels by ACE. That angiotensin 2 goes off to the heart and systemic circulation, to our kidneys, to our brain, modulating and helping us stand upright. Any angiotensin 2 that should leak out into the tissues comes across the ACE2 on the cells and is converted to angiotensin 1 to 7, and so everything's calmed down and those cells are protected from inflammation. Now, it's not hard to see what will happen if you have COVID and you've taken away ACE2. The angiotensin is still formed, it still goes off to the circulation, but this angiotensin 2 floating around in the space between the blood vessel and the air sac is no longer mopped up. There's no longer the anti-inflammatory angiotensin 1 to 7 form, and so, of course, it isn't surprising you get such nasty lung damage. So I think that pulmonary ACE2 is essential for protecting the lungs from the very high levels of angiotensin 2 forming in and passing through the lungs. I've got to apologise with this slide, but there's another point that I wanted to make that I think is really quite interesting. In this slide, showing you a whole lot of technical words about inflammation. These terms are all part of the process of causing tissue damage and inflammation. And these processes are all activated by angiotensin II acting on its angiotensin 1 receptor. Here on the right, we have our lovely, kind, gentle ACE2 angiotensin 1 pathway with the MAS receptor. And you can see, if you look across, that it really does, and this has been shown experimentally, downregulate all the inflammatory pathways that this pathway activates. So that's our natural balance of between these two systems, keeping everything ticking along. Along comes SARS, and it takes out this system, leaving this one unopposed. But there's something even more sinister. On the SARS spike protein, they have identified a number of proteins that in actual fact have exactly the same actions as angiotensin II does through its AT1 receptor. And so it's as though it's come along, kicked the nice guy off the block and entered into a bullying situation with the bad guy on the block. So then they are working together. I wanted to point out one of the things both of them do is activate this substance TNF-alpha. And TNF-alpha is activated through that enzyme TACE that I mentioned earlier. So the system's all linked together. And this activates clotting in blood vessels. The reason I wanted to make a point of this is that frequently you'll read in the press about thrombi and clotting and all these bizarre things, and also the syndrome that occurs in children, which looks like a vascular disorder and is similar to Kawasaki syndrome, that may and is certainly related to COVID-19 and may be related to this interaction with their bloodstream, with their blood. So what we have then is the coronavirus, COV2, really doing a smart act. It destroys the ACE2 anti-inflammatory pathway, leading to high Ang2. It produces proteins that invoke inflammation and cytokine production. And angiotensin II potentiates these actions of the COV2 proteins in inducing inflammation. So does it play a key role in severe COVID-19 infection? Well, in animals, you can cure lung inflammation caused by SARS virus by injecting a renin-angiotensin blocking drug. Remember way back I showed you that slide of the decreased mortality in humans being treated with an renin-angiotensin blocking drug. And you can actually do the experiment in animals and show that this happens. So angiotensin II AT1 receptor is overactive in COVID-19, interacts with the viral proteins, helps generate TNF-alpha. Well, how are we going to stop this in this current situation where vaccines are being developed and hopefully they will be very successful? But there are other treatments available, potentially available. Don't let the virus get into the cells. Nafamostat is an inhibitor of that enzyme that's essential for the virus to enter the cell. We could mop up the virus. We could give soluble ACE2 without the subunit. We can make it in the laboratory, and we can give that to a patient, get that to bind to the virus. Now the virus is unable to bind to the membrane-bound ACE2 and get into cells because it's a membrane-bound ACE2 that allows the virus to get into the cell to replicate, and it's the membrane-bound ACE2 that protects the cell from the angry actions of angiotensin by the AT1 system. Or we can block the angiotensin II AT1 interaction and lower angiotensin II levels, or lower angiotensin II levels. Now, these are the two actions that underpin why we use the renin-angiotensin system blocking drugs to lower blood pressure and hypertension, to protect the kidneys of patients who have diabetes mellitus, to help the heart when it's in heart failure. All these actions are integral to treating these conditions. So if you took these drugs out and the patient had SARS, you can imagine they would get very much sicker. So my conclusions are, if you're taking RAS-blocking drugs for high blood pressure, diabetes or heart failure, and you get COVID-19, don't stop taking them. You'll be sicker. Should they be used to treat COVID-19? Well, drugs that block angiotensin 2-AT1R do stop SARS protein causing lung inflammation in animal models. And they have been used to treat acute respiratory syndrome. So it's not surprising, I guess, that some clinical trials of these two agents are finally being carried out. But what I don't understand is why this story has not had the publicity of the story of, for example, of hydroxyquinone, because there is a very sound scientific basis for looking at these drugs in the treatment of COVID-19. And I suppose my take-home message is look to the science, not to the fiction. But this is a world in which fake news wins. Thank you very much for listening to me.
Eugenie, can you hear me?
Yeah.
Okay, so we have several questions coming, so please use the Q&A session to ask questions. The first question is from Roger Smith. So Roger asked the question about the S2 enzyme. So he asked, what about African origins? Do people from Africa have higher S2 level?
Are you talking about ACE2 levels?
Yes, S2 level.
There's absolutely no evidence about why the Afro-American is more susceptible to COVID-2 infection than the non-African American at this stage. The two papers that I cited about there being lower levels of serum ACE2 in young people and in females compared to old people, and the lower levels of ACE2 in the nasal passages of young only appeared last week. So I guess people are working on it, but nothing's turned up yet.
Okay, he also have a following up question as well. So the question is that, are there polymorphisms in this receptor that vary by ethnic origins?
There are polymorphisms, and there is a polymorphism that, changes activity. I have no idea whether anyone has even begun to look at the ethnicity of these polymorphisms. We have looked at the polymorphisms of the renin-angiotensin system in Indigenous Australians, but we unfortunately didn't look at ACE2.
Thank you. So I hope if Roger has some more following up questions, so he will put that in the Q&A. So the next question is from Ian Bryce. The question is, how is a coronavirus related to a rotavirus? So it sounds similar to him.
Well, actually, this is where I display my ignorance. Rotaviruses are gastrointestinal infections. They are a very different family of viruses. I can't tell you much about their structure. The coronaviridae family is about 36 viruses. There are an awful lot of them, mainly in animals. Bats are loaded with them, but they're everywhere. In fact, the Middle Eastern SARS virus, Middle Eastern respiratory syndrome virus, you get from camels. So they are right throughout the whole animal kingdom. And as some other one, this very famous, they call her the Bat Woman in China, who's been studying them at the Wuhan Virology Laboratory, which has been the basis of so much political football, claims that, we're just sitting here waiting for the next one to come down the track, as it were, as they mutate and as we get closer and closer to the species in which they're carried. The coronavirus, a very specific group of viruses, one family.
Okay. The next question, I think the next one is more like a comment that Roger Smith has posted on a Q&A. So he comments that, so it's brilliant strategy for the virus to target S2 as it's so highly expressed in the lungs. So you want to add any more comment into that, Eugenie?
Well, I imagine, I'm no clinician and I don't have that expertise, but I, for example, imagine you could have, if somebody started to test COVID positive, you actually gave them a nasal spray or an inhalational spray of soluble ACE2, which then would hopefully mop up the viral particles before they could get into and cause the damage to the pneumocytes.
Yeah. Okay. And the next question is actually is from John Aiken. So he has two questions. So I'll read the first one first. So John asks, could COVID cause infertilities?
Yes. Well, no, we don't know yet. Again, it's there was a mysterious report from Wuhan about males who've had COVID-19 being tested for infertility, but it hasn't been documented. There is a lot of ACE2 in the testes. I haven't heard or found a reference to causing infections, but I do think there is a theory floating around in the literature that it may affect spermatogenesis and may have nasty effects on sperm development. But it's not an area that I've been looking at particular detail.
Yeah. Okay. John also have another question. So could COVID become a sexually transmitted disease?
That's an interesting one. It's certainly, there's ACE2 in the ovary. I don't know that there's any evidence that it causes infections. SARS causes infections in the ovary. Would the damage to the tissues in the testis, if there is a substantial testicular infection, lead to a sexually transmitted disease? I don't know. I suppose one of the things that's important is that the testis has a blood testis barrier. And so it may be rather difficult for the SARS virus to get into the testis anyway. But we don't know. I mean, and where we're interested is in pregnancy, and there are reports of infection in the placenta, but we don't understand how it gets there because nobody's actually been able to show much COV2 in the blood. So there's an awful lot to be learnt. And what's sad is, of course, that opportunity was there when the SARS epidemic was back in the early 2000s, and nobody followed it because it didn't make money.
Okay, thank you, Eugenie. So the next question is from Jeb Mulhern. So the question is that for those of us who do not have the scientific and technical understanding of your talk and others' published materials, is there any simple steps we could take that would help protect us based on the information given by you?
No, I'm sorry. I'm giving the scientific story, and it is up to the epidemiologists and the clinical experts to tell you what to do, and we all know that very well. Distancing, keeping clean, keeping our hands washed. There is nothing, I think, that helps us. Having a healthy diet is important, I think, in any resistance to infection. But just general things like that, to keep your immune system active and keep healthy. And I suppose if you belong in the overweight group, to try and lose weight.
Okay. I don't see any more questions coming. There's only a few comments that Roger has mentioned in the Q&A channel. So the first one he mentions is that African American tend to be heavier than the white counterpart. So I guess that is that the key that they have high S2 level that make them more susceptible to the coronavirus?
Well, as I say, I haven't seen any evidence for African. I haven't seen any evidence that establishes that. It may well be the case. Just what is particularly interesting to understand is that the animal literature was a bit misleading with the age dependency of ACE2 compared to what's now turning up in humans. So I think you really have to go out and do the work and measure it and then try and correlate it with the epidemiological profile.
Yeah. Thank you, Eugenie. And Roger Smith also mentioned in the Q&As that rotavirus had double-strand RNA virus, while coronavirus are single-strand RNA. I guess Robert just want to add into your answer as well.
Yeah, I forgot it was a single-strander.
Yeah. Okay. So are there any more questions that other people want to post on the Q&A? I have one question, Eugenie. Just a quick one. So how far ahead you think until we get the vaccine being active?
Well, I think it's already. It must be there. There are neutralizing antibodies that you can show the SARS compared to the CoV-2. You can show there's cross-reactivity with the spike protein. So it can't be too far off. What has made everybody very nervous is that when they did test a vaccine for SARS, it produced a massive sort of cytokine storm. In other words, it made the condition very much worse. And that was possibly because the antibody wasn't powerful enough to block, that was produced wasn't powerful enough to block all the actions of SARS. And so you've got this enhanced storm of trying to protect against infection. But so far as I read it, that hasn't been seen in any of the experimental models. And I'm sure it's going to be there. But again, I know nothing about making vaccines. It's a very, laborious work to make enough to cover everyone.
Okay. I think we'll just take one last question from Trevor, and then we might end this Q&A question. So the last question is from Trevor. So he asked that, do other coronavirus act the same way as COVID?
None of them are, SARS is very nasty. Sorry, let me retract that. SARS and MERS have very high infection rate, a very high mortality rate. None of them are as infectious as CoV-2. CoV-2 really loves that ACE2 receptor and has a very high affinity for it. And that possibly accounts for why it is so infectious. The other viruses are not so infectious. MERS uses a different receptor, doesn't use ACE2. And that funny one that I mentioned, which is responsible for 10% of infections in children, that is causes a mild respiratory illness, although it can cause bronchiolitis and croup. But interestingly, that doesn't shed the ACE2 doesn't cause the ACE2 to fall off the cell membrane. So the ACE2 is left on the cell membrane and the virus binds to it. It doesn't do the destruction that COV2 does or that SARS virus does.
Yes. Stuart, do we have a few more minutes for the Q&A? I just got 2 more questions coming.
Yes, absolutely.
Okay. So, Eugenie, you could comment. So it's a question from George Pasinos. So are we more exposed to these viruses with the damage to the forest? I guess because lots of this virus is from animals, from the wild animal. So with the damage to the forest, are we more exposed to this virus?
I think, George, it is generally accepted that we are, as we take out the forests, as we invade the natural environment, we are exposing ourselves to zoonotic diseases, perhaps on a scale that's never occurred before. And I'd put Zika virus into that, although I'd put Ebola into that, and I think the coronaviruses are the same. The bat is particularly interesting. I don't want to malign bats because I think they're rather sweet animals, but they are the only flying mammal. Now, that means that they are more likely to, they're closer to us in terms of being able to give us an infection because they're a mammal, as distinct, say, from birds. Although there is bird flu and all those other ones. So I would say that, yes, we are paying the price, or nature's way of perhaps telling us to start thinking about our natural environment for our own health in more ways than one. Yeah.
So there's another following up question from Joyce as well. Do the forests hold reservoir of old and future viruses?
Oh, yes, I think absolutely so. I think that is, the wet markets, I suppose, are this place where there's this closest proximity between animals that have been captured in the wild and brought in to be sold. And, I mean, they have, I've seen those markets and they have all sorts of wild animals. And, of course, that's, I think, why there's such a, move to let's leave aside the absolute cruelty and the total unethical way in which those wild animals are treated. But it's also very good reason not to have them is for human health reasons.
Okay, thank you, Eugenie, and thank you for everyone who asking the questions. Now I pass the forum back to our Chancellor, Paul Jean, to give a vote of thanks and bring the meeting to the end.
Well, I really like to move a vote of thanks to 4 recipients. And first and foremost, of course, to Eugenie. It's been a riveting talk, Eugenie, and I think that's demonstrated by the breadth and depth of the questioning that followed. It's been a great speech. To Natalie for fielding and disseminating those questions. To Stuart as our host, the webinar itself, and it's, as I mentioned before, our first attempt, seems to have been very successful. And lastly, but not leastly, to our audience. It's been a great experiment. I think it's proven itself to be successful, and I'm sure we'll want to follow up with more public addresses under these constrained circumstances through webinars. And to the audience, finally, we as a hunter branch of the Royal Society really want to expand our influence and interest. So I encourage all of you to stay in touch, to participate, however you might wish to do so. But we've got a great website, and Natalie's the author and pilot of that. So the means are there to stay in touch. And let's look forward to some more enjoyable and informative nights like tonight. So thank you all very, very much. Thank you, especially Eugenie. Keep safe.